interesting topic of chronic pain management. So chronic pain is a big problem. It's the reason why many patients keep coming to hospital. And we hope that you can stay through the webinar so that you learn what is new in chronic pain management and what it is about. This afternoon, we are joined by a very wonderful speaker, Dr. Hussein Elias from Moi Teaching and Referral Hospital College. Dr. Hussein is a consultant family physician and he has vast experience in pain management and palliative care. He is very experienced in medical education and community health, and currently he's the program director for the higher diploma in palliative and hospice care for clinical officers. And soon he'll be bringing to us a fellowship in palliative medicine for medical specialists. Dr. Hussein, feel free to share your slides. You can start your presentation. If you have any questions or comments, please type in the chat or the Q&A section as we go along.
Good afternoon, everyone. Thank you so much, Dr. Nafula, for the introduction. I would like to share my screen. Please, if you can bring down, or can I just still continue sharing?
Try and start sharing. Yes, thank you.
Thank you so much. And as Dr. Nafula said, my name is Dr. Hussein Elias. I'm a consultant family physician, and I'm also a lecturer at Moi University Department of Family Medicine, here community health and medical education. And I'm also program director of at the MTRH College of Health Sciences for the higher diploma program of palliative and hospice care. And yes, soon we'll be starting our fellowship in palliative medicine as well. So you're all welcome. So I want to talk about today on the chronic pain. Management of chronic pain is actually a very, very broad topic due to the complex nature of this chronic pain. So today I want to just see if I can focus more on the use of opioids in chronic non-cancer pain. There's a lot of discussion at the moment ongoing on the safe use of opioids in chronic non-cancer pain. And so today I want to see if we can talk about this and discuss more in the question and answer session. To continue, I want to begin with a clinical case. This is a clinical case that I personally came across during a home visit on making in the communities of a 91-year-old female patient who had this continuous pain in the right lower limb from the hip to the toes, the pain on the left knee, and also the ankle. The pain score, according to her, was 8 out of 10 on a numeric pain rating scale. And in addition to that, she had this loss of appetite. More on pain, the pain was worse at night, which was causing her to be asleep. And the pain was worse also during any movement that she would make. That made her to become bedbound. The pain in nature was dull, becomes very sharp with any movements, and she was also experiencing a burning sensation on the same limb. So she has been bedbound. This came in after a surgery which was done for a right neck of femur fracture a year ago, and she usually uses bed pen. She was not even able to get out of bed to use a bedside commode, so she was totally bedridden at that point. So for pain management, she's been using diclofenac on and off for over 10 years now with minimal relief. And on examination, the vitals were normal, musculoskeletal. She didn't have any obvious swelling. The extremities were not warm on touch. They were not hyperemic. But there was reduced active and passive range of motion for both hip joints and right knee joint. And the left knee joint has a normal range of motion, but had these crepitations. So it brings us to a very important question here, looking at her case where she was using diclofenac, but still she had this pain. She had this insomnia. She was not able to sleep. She was bedbound, was not able to get out of bed. So it brings us to a very important point on using of opioids. Now that we also know about the adverse effects or the NSAIDs can bring So how safe are opioids for her? Will they reduce her pain and improve her quality of life? And if the answer is yes, then what would be the duration? Will prescribe the opioid, knowing the problems that opioid can bring. So pain, as we know, this is an unpleasant sensory and emotional experience, which is associated with the actual or potential damage. It is one of the most common reported health problems and the reason to multiple hospital and clinic visits. I mean, in the clinic, in the hospitals, one of the most common presenting complaints which patients complain about is pain, and that is the reason even why they come to the hospitals. It is something very subjective. Pain is something very subjective. That's why we always have to believe when the patient says it is there, the patient says that there is pain, we have to believe the patient, and it's very individualized. Over time, if the pain is persistent and there is absence of tissue damage, or after tissue healing, there is still pain, the pain itself can become a disease. And pain is also linked to psychosocial cause. So it's not only the physical cause of pain, but there is also the psychosocial component of it. And pain can be classified as, depending on the type, as nociceptive, neuropathic, and/or nociplastic. So nociceptive is when there's involvement of the somatic receptors, which are in the body tissues. Neuropathic is when there's involvement of the nerves, peripheral and the central nervous system. And there is new, which is not yet clinically used, is what we call the nociplastic type of pain, which is not either nociceptive or neuropathic. This comes about mostly it's with the chronic pain syndromes, and it comes about because of central sensitization when there is this nociplasticity of the central nervous system, which can lead to cause nociplastic pain. And in terms of duration, pain can be classified into acute and or chronic pain. So some definitions of importance is one of them is acute pain. This is a rapid onset of pain. Usually it's short-lived, caused by an ongoing nociceptor stimulation or inflamed tissues or abnormal sensitization of neurons. There is the time frame, they say it's 3 months and more, as defined by the International Association of the Study of Pain. So the it's as we know, has multiple etiologies, and sometimes the etiology is unknown or not found. It carries a biopsychosocial model because of the mixed etiology. So there could be and requires an interdisciplinary team to assess and manage. There could be multiple factors in play here to cause this chronic pain. Some of the chronic pain conditions have no clear cause, and these are examples of fibromyalgia, chronic headaches that we see. This is a cycle of a persistent pain, which I wanted to share, is telling us that because of pain, you can have other factors that can come into play, like you become less active, which will cause loss of fitness, weak muscles, joint stiffness, then cause sleep problems, tiredness, fatigue, which can cause stress, fear, anxiety, involving the psychological element of it, leads to weight gain, start thinking negative of the future, having depression, mood swings, taking time, work off, thinking about money, worries, relationship concerns. So again, now the psychosocial element comes in play here, and this again causes more pain or persistent pain. So it's I call it a vicious cycle because it keeps rotating around. So when you're talking of management of chronic pain, it's all about thinking how can we break this vicious cycle. So because of this vicious or the pain cycle that we saw, the assessment and treatment depends on the complex biopsychosocial factors that are in play. And some of the biological factors is the extent of injury, damage, or specific predisposing factors. The psychological factors could be anxiety, fears, depression, and social factors like work, environment, family attitude, the family support that we get, the community support, and beliefs, various beliefs which patients can have. So about a little bit on surgical and trauma pain. So what we know about surgical and trauma pain is there is tissue damage, which will cause inflammation, which will lead to stimulation of the pain receptors and causes pain. This is usually a short-lived because the inflammation is that as the tissues get healed, the inflammation reduces, and therefore the stimulation goes down and the pain kind of resolves spontaneously. So it's a very short-lived as the repair occurs. On the other hand, about cancer pain, now tumor itself can secrete modulators, direct modulators of pain, which impact the spinal cord and signal the CNS. Cells in the tumor microenvironment can also stimulate the neurons. Now, something of importance here is knowing about the possibility of reorganization of the CNS from the long-term stimulation itself. Now, that itself can lead to chronic pain, whether the damage or the tumor secretes or the cells in the microenvironment stimulates the neurons or not. There is that CNS reorganization which takes place, which can now lead to persistent pain. So there's still a need to better understand and answer some questions, which are we need more literature, more evidence to be able to answer these questions. So some of the questions are like chronic pain appears to alter the brain architecture, that is the sensitization of the brain or the organization of the brain, neural pathways, and can this be prevented or can it be reversed? Cancer pain usually does not correlate with the size of tumor or other parameters. Two patients having similar cancers, but their response to pain would be free. Some might have crippling pain and others with the same disease are pain-free. 10% of the population post-surgery can develop chronic pain. So why? Patients with somatoform pain are much less likely to respond opioids. Is there a connection with mental illness or are there any common pathways? And there is a high incidence of depression and anxiety in patients with chronic non-cancer pain. So it's still not clear, or we are still not aware of what comes first. Is it that this patient had depression and anxiety before developing chronic pain, or is it the chronic pain that is causing the depression and the anxiety? So it's like a chicken and or egg story. And certain patients are at high risk of opioid abuse. Prevalence of chronic non-cancer pain. So although considered a high prevalent condition, exact incidence and prevalence is difficult to estimate. This is because it is usually treated as a symptom of another medical condition. For example, in osteoarthritis or plantar fasciitis. So we normally treat as osteoarthritis or plantar fasciitis, but not as a chronic pain or a chronic non-cancer pain. So therefore, it becomes very difficult to estimate the exact incidence and prevalence. The prevalence in developed countries is around 40%, whereas in developed countries around 20%. This could be because of fewer studies from developing countries and because of its probably just being managed as a symptom of another medical condition. In America, the estimate is around 100 million adults have chronic pain, and chronic non-cancer pain has been considered as amongst the 10 most prevalent diseases worldwide. Surveys, evidence from some of the surveys that have reported the incidence and prevalence show that WHO survey indicated a 20 to 30% prevalence in various primary care clinics globally, whereas in UK and South Africa, the primary healthcare practice documented a prevalence of 50% in the UK and 41% in South Africa. And from more local studies from South Africa, Uganda, and Kenya, especially in HIV patients, the estimated prevalence was ranging from 59 to 98%, which is pretty high. And so it has been estimated that the prevalence will continue increasing. This is because of the increasing age, increasing incidence of non-communicable diseases, rising prevalence of obesity, and chronic pain usually impacts negatively on the quality of life in multiple ways. And with this increasing incidence and prevalence, we should expect a huge burden. This is a 2013 study, more local, which was done in Western Kenya, a referral hospital. They're looking at around 400 hospitalized patients admitted in a national referral hospital, and trying to check on the pain assessment and administration of analgesics. So the findings from this study show that the pain prevalence among hospitalized patients was 80.5% and 30%, was around 80.5%, and 30% of the patients experienced moderate to severe pain. This included all patients with cancer and acute and chronic pain. Older patients and patients with HIV and cancer had higher pain ratings. Majority of the patients had undertreated pain. So this tells us that how poorly we treat pain. HIV and adult patients were more likely to have undertreated pain, and 2/3 of patients were prescribed pain medicines. So it was only 2/3 out of all these patients who were prescribed pain medicines, and only half of the patients were on non-opioids, whereas only 1/3 were on weak or strong opioids. So the question comes, should we see how we can optimize? Should we have more use of opioids to manage this pain adequately for patients? So the burden of chronic non-cancer pain. In 2016, the global burden of disease reaffirmed that pain and pain-related diseases were the leading cause of disability. So of importance is that the burden is escalating, and there's a higher probability of developing depressive symptoms and risk of suicides when compared to the general population. So there's literature showing that risk of probability of developing depressive symptoms because of chronic non-cancer pain is 2 to 5 times higher compared to the general population. And chronic neck and migraine pain have been ranked to be among the top 10 causes of year lives with a disability. So for depressive symptoms, they can cause poor sleep, affect social life, and now the poor sleep may worsen the pain intensity, may compromise the daily activities and routine work, causing social problems. Reduced daily activities can reduce muscle strength, flexibility, which may be associated with fatigue, weight gain, and less overall productivity, which then increases disability, increase economic burden, consumes healthcare resources. So it brings us back to our the cycle, which I call it the vicious cycle of persistent pain, where because of pain, you end up developing other psychosocial problems, which bring back and worsen your pain or cause persistent pain. This is a study, a South African study, showing on the nature and magnitude and of the impact of pain on the quality of life of patients with chronic pain. I did not come across any more local studies. Therefore, this is the closest I could pick from Africa. So what it shows, this is a prospective cross-sectional study done in 4 primary healthcare clinics in South Africa, and half of the patients had chronic pain, with 2/3 of the population being female. Around 96% of patients reported that the chronic pain had adversely impacted their quality of life in varying degrees, and 68% reported being severely adversely affected. So this tells us on the high burden chronic pain can bring. Like more than 50% of the patients had reported a severely adversely affected quality of life. So the severe negative impact was mostly on the sleep quality, the mood, the interpersonal relationships, enjoyment in life, working ability, routine household work, and increase in pain intensity was associated with poorer quality of life. So these are some of the negative impacts which unresolved pain can bring, from the psychological and the social factors. So it can bring decreased productivity, loss of income, inability to concentrate, fatigue, increased healthcare needs and costs, reduced functional capacity, impaired relationships, suicide risks, insomnia, depression, anxiety, a lot of mental health issues as well, and reduced self-esteem. So a little bit on the opioid pharmacology to understand opioids. So it's classified by strength, weak opioids, strong opioids, duration of action also. So you can have like immediate release or slow release opioids. They usually work through the opioid receptors, which are the mu, delta, and kappa. But most importance is the mu receptor. There are various ways of how we can administer. It could be intravenous, oral, intramuscular, buccal, sublingual, transdermal, rectal, parenteral. There are various ways which can be used, epidural and intrathecal routes. But there is little evidence that shows the superiority of one route over the other in management of chronic non-cancer pain. Change of route may improve the effect, the analgesia effect, the adverse effects, and the compliance of these drugs. So of importance is to understand the adverse effects. There are various adverse effects which opioids can bring, and one of the common side effects that we see in opioid use is the drowsiness, constipation, nausea, vomiting, itching, sweating, mood change, hyperalgesia, and endocrinological suppression. It has been noted that 80% of individuals will experience at least one side effect, and because of this may lead to a non-compliance or discontinuation of the treatment. Caution is about the toxicity from opioid, which is respiratory depression and the risk of addiction and drug misuse. The use of opioids in pain. For cancer, we have evidence showing that it's highly effective. Abuse is reported in less than 2% of the patients. There's lower chances of tolerance. And the initial studies has been done in patients with relatively short prognosis, but as compared to non-cancer chronic pain. So the effectiveness will vary depending on the cause. There's a very high risk of abuse. Tolerance is more common here, and patients may have long or normal life expectancy. So therefore, again, its use and the duration becomes questionable here. So looking at this too, again, the question comes on the safety or how safe is opioid use in non-cancer chronic pain. So currently, opioid has been used for the past 2 decades in the Western world to manage chronic non-cancer pain. WHO has recommended as part of the analgesic ladder in cancer pain, which includes neuropathic pain. This previously, much earlier, opioids were considered as an appropriate strategy because of the safety campaigns then, but over time that has changed. And there are reviews, systematic reviews and meta-regression of observational studies in 2020, which reported that around 30% of patients with chronic non-cancer pain are prescribed opioids. And usually it's the stronger opioids that are prescribed more commoner compared to the weaker opioids. So what we know more about opioids is that the primarily effect is through the mu receptors. And now the mu receptor also mediates the reward effect of many abused substances. So because of this, there's a very high risk of or a tendency of misusing or abusing opioids because of the reward effect from the mood receptors. So some of the key observations in substance use disorders is that the patients with the substance use disorders are more sensitive to painful stimuli. There is extended periods of exposure. The extended period of exposure to opioids can exacerbate chronic pain. And there's evidence showing a clear genetic component of substance use disorders amongst patients, pain perception and depression. And they may be interlinked between each other, which could put you at a higher risk of substance use disorder. So some of the important questions in the history to ask before deciding to put a patient on opioids, and some of the important considerations to consider at that time is it's important to understand that some patients with chronic pain may be treating their pain with alcohol or other non-prescribed opioids, other drugs, and there is a risk of overdose if the patient is using other drugs, and if it's unknown, we don't know, and we decide to prescribe opioids, so there is a risk of overdose and toxicity because of that. Therefore, it's important to know from the history of the patient. But the history itself or of abuse is not a reason to withhold pain medication. So it's also important to optimally manage the patient's pain. The other important element is that the hospital should be able to set up policies, or the clinic should be able to set up policies and guidelines on safe opioid dispensing and prescribing ways. So about the refills, so to have clear rules on refills of the drugs, drug surveillance, and who the prescriber is going to be, and also a need to engage the addiction specialist and the involvement of the mental health team, looking at the high incidence of mental illnesses in our population, or in this population. So this is a simple tool. It's a 1-minute tool, opioid risk tool, that can be administered to assess the risk of opioid abuse in patients. So it's a tool that can be easily used at the clinic with the patient or at bedside. So it's important to understand the chronic pain, depression, anxiety, and the risk of substance use disorder. So because of pain, you end up requiring more medication, reducing activity, which can lead to muscle tension, progressive deconditioning, leads to insomnia. Because of that, you end up developing tolerance to the pain medication. So you end up requiring higher doses of your opioids, which again can cause the adverse effects, and then the pain itself can cause more pain, which can cause decreasing in activity, requiring more medication, leading to fatigue, which can now put you at a risk of developing physical dependence. And at that point, you end up requiring more medication, the risk of developing depression and anxiety, hyperalgesia. You become over reliance on medication. Now that can cause, again, a psychological dependence and issues, anger, anxiety, fear, further avoidance of activity, and increased perception of pain, causing more pain. So again, this is now the putting our vicious cycle into now the risk of developing substance use disorder and chances of our risk of developing depression and anxiety. So how this pain itself and the use of opioids can cause put you at risk of developing substance use disorders, develop depression and anxiety, can cause more pain, and leads to dependence as well. So this is a 2008 study, which is a systematic review of meta-analysis of efficacy and safe use of opioid therapy for chronic non-cancer pain. And this showed that this was for a duration of 6 months, and it showed that many patients withdrew from the trial because of the adverse effects or due to insufficient pain relief. But the sign of opioid addiction and abuse was reported as low at only 0.05 and 0.45% of patients. The pain scores were reduced after long-term opioid use. So in conclusion, what concluded was that many patients discontinued the long-term therapy because of the adverse effects and insufficient pain relief. However, they were able to conclude that there is weak evidence suggesting that long-term opioid therapy reduces pain in relatively a small portion of patients with chronic non-cancer pain who continue treatment. So this tells us that probably there is some evidence, although weak, to show that opioids can be prescribed for chronic non-cancer pain. 10 years later, this is another study, a systematic review and meta-analysis of 20 issues done in 2018. And here they had clear primary outcomes, which was the pain intensity, physical functioning, and incidence of vomiting as one of the adverse effects. And what they showed that high quality studies showed opioid use was significantly associated with small improvement in pain and physical functioning, and there was an increase in vomiting compared to placebo. So they concluded as the conclusion was moderate to low quality studies showed similar benefit between opioids and non-opioids for pain and physical functioning. So this also, in terms of high quality studies, they show a small benefit from the use of opioid in pain improving pain and improving the physical functioning as well. So this was 10 years later from the previous study. So both studies are showing that a small benefit from the use of opioids in the management of chronic non-cancer pain. So this brings us to a very important point on if there is a small benefit, then the question who benefits from it and how do we go about prescribing opioids, considering the risk which are from the opioids as well. So looking at what lessons we learned from the Western world. So in the Western world, opioids has been in use to manage chronic, and for the past 1 decade, it's one of the most commonly prescribed medications. And this spike came about in prescription of opioids came in after the safety concerns of long-term use of NSAIDs, which are issues with the kidney, cardiovascular, and stomach. So medical and non-medical use of prescribed opioids has created an epidemic of prescription, which leads to opioid overdose, emergency department admissions because of opioid overdose, risk of addiction, diversion, and death. So it is one of the epidemics the Western world is struggling with at the moment. The increased rate of substance use and depression exists in long-term prescription opioid users compared to non-users. And there is a risk of developing tolerance and physical dependence at even prescribed doses or even at lower doses as well. In Kenya, so in the recent past, there's been a number of advances in expanding access to pain relieving medications, and which also includes opioids. So Kenya has adopted the WHO list of essential medicines, and use of morphine in Kenya has increased threefold compared to between 2010 and 2014. And I'm sure it must have increased much higher till now. So with the increase in advocacy and accessibility to opioids, there is a need to fund safe use of opioids in chronic non-cancer pain, with evidence showing that of the small benefit of use of opioids in these patient groups. So it's important to weigh the risk and the benefits. Therefore, important to ask ourselves questions on the goals for use of opioids. Why are we prescribing opioids for this patient, and how will it help? So one of the goals, some of the goals that are set is reduction in pain, improved sleep, improved mood. Will this help getting the patient to return to work? Will this improve physical functioning and social functioning? Although there's uncertainty of long-term benefit of opioid for chronic non-cancer pain, Therefore, it is very important to set an achievable goal together with the patient. It's a discussion you have with the patient to set an achievable goal, and the duration setting, because there is no general consensus on the outcome measures and on the duration as well. So therefore, there are various existing tools that can be used to measure the goals, to assess the outcome. And this tells us that about the frequent reassessment requirement, need for these patients is important. I like this German guidelines. Therefore, I would like to share these guidelines. These are the guidelines for long-term opioid therapy for chronic non-cancer pain, and it's a second update of the German guidelines. It's a recent document. So it's very important, before starting opioids, optimize your non-pharmacological and alternative pharmacological treatment options for patients. And when the patient is not responding, is when now start thinking about should we start opioids for these patients. Opioid treatment should not be the only treatment for chronic non-cancer pain. So opioid analgesics should be there to complement the other non-pharmacological and alternative pharmacological treatment options patients are undergoing. Try and utilize more of self-help resources, even providing patients with self-exercise program, papers, documents, or resources which they can utilize to help them. These are resources like physical, physiotherapeutic, and or psychotherapeutic techniques, which includes patient education or lifestyle modification should accompany any drug treatment or pain for these patients. So the selection of drugs, before you select the drugs, you should consider the type of chronic non-cancer pain you are dealing with and you want to use your opioids for. Consider the comorbidities of these patients. Normally, elderly patients will come with a lot of comorbid conditions, and also not forgetting the mental health problems these patients can come about. If there are any contraindications to use other treatment or on the use of opioids, what are the patient's preference? Therefore, putting patient in the center of the discussion is very important, and allowing them to be able to decide, making a well-informed decision after understanding the benefits and the risks of the drugs, and trying to do a benefit risk ratio for the available pharmacological and non-pharmacological alternative treatment options for these patients. So the starting rules, there is evidence based recommendations based on RCTs with opioids, which are available for chronic low back pain, osteoarthritic pain, and some neuropathic pain syndromes like diabetic and non-diabetic neuropathy, herpes, neuralgia, restless leg syndrome, radicular pain, phantom limb pain. Opioids should only be used when in cases of chronic low back pain. Opioids are only advised to use if there is a relevant somatic factor or if there's an underlying problem in the onset and the maintenance of the chronic low back pain. This is according to the assessment, and these patients don't respond to non-pharmacological treatments. And in cases of chronic osteoarthritis, opioids should only be used when there is a failure of non-pharmacological treatments, failure or contraindication on the use of other analgesics, and if joint replacement is not possible or refused by the patient. So it's important to set clear treatment goals before you start your treatment, and these goals should be set together with the patient, and the goals should be individualized, and they should be realistic in nature. The initial dose, optimal dose, and treatment response. So always begin low, start with the lowest effective dose or the lowest dose for these patients. And reassessment is very important to assess the effect of the treatment and the adverse effects of the treatment. And gradually, it also helps in readjusting the dose, either escalating or de-escalating the dose. The optimal dose is considered when the previously determined goals of treatment have been attained and the adverse effects, if any, are mild or tolerable. Usually, when doing morphine or morphine equivalent, so a dose of 120 milligrams per day should only be exceeded in exceptional cases. So this tells us that you should be careful not to exceed that dose. When you are reaching at that level of treatment, then a reconsideration should be considered, whether should we continue the treatment or something of other possible causes. And depending on now the case itself, only in exceptional cases where you might want to go higher than that dosage. Long-term treatment, so longer than 3 months should be restricted to patients identified as treatment responders. Only those who are achieving their goals with minimal side or tolerable side effects. So you can consider to continue with the treatment for longer than 3 months. Stopping rules. So evaluation at regular intervals is very necessary. So whether the treatment goals are still met, check for presence of any adverse effects. And we talked of some adverse effects because of opioids, like loss of libido, mental changes, loss of interest or attention deficit falls, or there is a chance or possibility of misuse of the prescribed drug. So an interval of 4 weeks is recommended for the initial phase of therapy. Opioid analgesics should be tapered if you reach to the individual therapeutic goals are not reached during the duration phase, maximum of 12 weeks, that's 3 months, or there's insufficiently treatable and intolerable adverse events that occur in the view of the patient and or the physician. Therefore, the opioids should be de-escalated at that point, thinking that probably there might not be any additional benefit in continuing the treatment. Discontinuation of the treatment for more than 12 weeks. This is when you're doing long-term treatment, then treatment should be tapered or de-escalated if the individual therapeutic goals are no longer achieved or insufficiently treatable or intolerable adverse events occur. The individual therapeutic goals are achieved by the medical, therapeutic, physical, or psychotherapeutic measures. If the patient uses the prescribed opioid in an abusive manner, despite concomitant treatment from an addiction specialist. Drug holidays. So after 6 months of opioid treatment, and it has provided a satisfactory response, like you do your opioids 2-3 months and the patient is responding well, you decided to continue, you go to 6 months and the patient is still doing well. So at that point, you should start a drug holiday should be reconsidered, either or reducing the dose or considering a drug holiday. So this is again a shared decision-making process with the patient, and looking at the need for continued treatment should be reviewed in a potential response to concomitant non-pharmacological treatments, like the multimodal therapy should be discussed at this point. So in conclusion, for chronic non-cancer pain, opioids can be used. That is only after non-pharmacological and non-opioid medications fail to reach the treatment goals. So opioid should never be considered as a first-line therapy in chronic non-cancer pain. Opioids are not superior. Something of importance to remember is that opioids are not superior to antidepressants and anticonvulsants for neuropathic pain. Therefore, again, it should not be used as a first-line treatment. So you should always begin for neuropathic pain, begin your treatment with antidepressants or anticonvulsants. For osteoarthritis and lower back pain, again, opioids are not superior to non-steroidal anti-inflammatory drugs. So again, it's not as a first-line treatment, and opioids still remain a valuable treatment option only if they improve or maintain the quality of life of patients who do not respond to non-opioids, or if the non-opioids are contraindicated to the patients. Always remember that opioid is associated with harms, and there's always risk of abuse these patients. Whenever you prescribe opioids to patients, close monitoring is very important to balance the benefits and the harms. So again, monitoring of the dosage, the adverse effects, the risk of abuse again, and the there is insufficient evidence for long-term therapy for more than 1 year with opioids. The evidence that is there, small little evidence, or the weak evidence that is there, has been for less than 1 year use of opioids, but more than 1 year, we don't have enough evidence to recommend continuation of opioids. So coming back to our case, so it's very important for this lady to set up goals for the opioid use, which should be improving the physical functioning, reducing pain, and improved sleep. So evaluating the benefit versus risk, that is the risk of adverse effects in this lady, the risk of addiction and abuse should be considered. And we can do a trial of opioids, but not as a sole treatment. We should consider starting physiotherapy, psychotherapy, and other non-opioids and adjuvants as well to help manage her pain. Assess her at regular intervals to evaluate for treatment response and adverse effects. And of importance here is if there's a patient similar with lesser symptom burden than this patient, then the first line of management would be non-pharmacological and alternative pharmacological options. These are some of the evidence showing for various chronic pain syndromes that are there. And if you look, most of in fact, all of them, there is weak evidence for. So you can use opioids for chronic low back pain, osteoarthritis pain, painful diabetic neuropathy, post-herpetic neuralgia, phantom limb pain, chronic pain after spinal cord injury, radicular pain, painful non-diabetic polyneuropathies, chronic pain in rheumatoid arthritis, restless leg syndrome. But for Parkinson's, there is evidence which is against the use of opioids. But the other, there is showing weak. So the quality of evidence is low to very low only, and the recommendation is weak on the use of opioids for these pain conditions. This is the contraindications for opioid use, where there is strong recommendation of use of opioids against, which is primary headache, functional disorders like fibromyalgia, irritable bowel syndrome. Chronic pain is a major manifestation of a mental disorder like depression, persistent somatoform pain disorders, generalized anxiety disorder, and post-traumatic stress disorder. Chronic pancreatitis, chronic inflammatory bowel disease, comorbid severe affective disorder, endosuicidality, and current medication abuse or passing on of medications to unauthorized person, and current or planned pregnancy. So there is strong evidence recommending against the use of opioids. So opioids are contraindicated in such in these medical conditions. Thank you.
Thank you so much, Dr. Hussein, for the presentation. There are very many good responses from the audience. It was a very good presentation. There are many queries about CPD points and accessing slides and the webinars. The research department will answer us, but I think they've been working on it. They've had a bit of a challenge, but they are trying to work on getting CPD points. I'm seeing some people are saying they have not received any points since they started attending the KNH webinars. Someone from the research department will respond to that at the end of this webinar. So we are having disease. What would be your opinion, Dr. Hussein, on management of sickle cell pain?
Thank you for the question, and thank you for the comments. So about sickle cell pain, yes, that's a bit of a challenge that we are facing right now, and especially in children. And they usually have this what you call a background pain that is always there. These patients, and the use of, so what I would say is, again, trying to see what best works for them and with the minimal side effects. So beginning with non-opioids is a good idea, but again, chronic or long-term use or continuous use of NSAIDs again has its adverse effects, which can cause issues with the kidneys or the stomach, leading to gastritis. And with sickle cell patients, they might also have what we call the sickle cell nephropathy, which again will be worsened by the use of NSAIDs. But coming in crisis, when they come in painful crisis, and that time they have the severe pain, so it's better to use the right dose of opioid at that point. But for background pain, you can be using NSAIDs, but again, it's not at continuous, but at intervals, depending like a PRN kind of dose, and but depending on the children also, which you're dealing with, so it's always good to start or combined use of ibuprofen or brufen together with paracetamol. Try and avoid as much using diclofenac in such age group in pediatrics. Yeah, but otherwise, there are other ways of trying to optimize this pain management, is making sure that the child is well hydrated, keep away from cold, child is warm, and when they're playing, so they shouldn't be out in the sun for long. They should try and be indoors, and using of course, patient education, family, parents education is important, and using of other non-pharmacological ways in terms of to manage. Yeah, thank you. I hope that answers your question.
Yeah, now the next concern, a lot of our participants have concern about opioid misuse, just the risk of opioid misuse, and whether really it would be safe that we do not use opioids at all to treat chronic non-cancer pain. But there are some very painful conditions like multiple sclerosis, fibromyalgia, that sometimes NSAIDs are not able to manage the pain because it is severe. Based on your presentation, Doc, what do you think would be the best way forward? Do we just say that we don't give opioids to anyone who does not have cancer, or what would be the safe way to use them?
Thank you so much for that question. And indeed, there is a concern. I personally also have a concern, because we don't want to get to a point where we are misusing our opioids. So in the beginning of my presentation, I said that chronic non-cancer pain is a complex problem which requires an interdisciplinary team. So therefore, you can do your pain management, and when you see that the patients are not responding, and now you feel that this patient might benefit from opioids, so that is where now it's important to involve the other team members of your team to help you manage this pain. Trying to set clear rules and or guidelines for opioid prescription for these patients, because looking at the burden these patients can have, I think that burden would be more harmful than not treating, or than using the opioids for these patients. So again, having clear set guidelines and rules for opioid prescription, involving other team members, or a team member probably who has more experience in the use of opioids, is important. Doing the assessment, a holistic assessment before prescribing opioids is again important. Seeing who is at high risk, who should be monitored or reassessed sooner, and how, and the reassessment, when should it be done, what should involve, setting up clear goals and targets, and seeing if you're achieving the goals and your targets or not. So those are all some of a lot of factors which will come in play here. But again, we should not deny patients optimal pain management, because pain itself is a huge burden. Thank you.
Yeah, now just following the same train of thought, what about the elderly patients? Because some of them get knee replacements, especially with arthritis, but their pain persists. And again, there's a lot of risks associated with NSAIDs. So we find in practice that some physicians are preferring to prescribe low-dose opioids to manage the pain, as opposed to keeping the elderly patients on NSAIDs for a long time.
Yeah, thank you. Thank you for that question. So, yeah, true. I mean, there's one of the unanswered questions that we have is, there is a probability, a chance of 10% of the patients who undergo surgery who end up developing chronic pain after the surgery. So again, and yes, indeed, it's very important, especially in the elderly, where there's a higher risk of when you use the NSAIDs for these patients, you might put them at higher risk again. So there would be some benefit, some small benefit of use of opioids. So it comes again down to what are our goals and have we optimized. So opioid again should not be the primary or the only treatment that these patients are for pain management. So it's about have we optimized our non-pharmacological options that are there, which could be psychotherapy, physiotherapies, again, self-exercise programs. There are quite a number which we could. Is there any role of topical, because if the pain is localized in one region, so is there any role of topical pain management in such patients? Again, but when it comes to the use of opioids, so again, clear goals and target should be set, and a plan for reassessment should be set for these patients. But again, from my experience, when we deny pain medication to these patients after surgery, they end up developing having this fear, they get anxiety, they become depressed, which will reduce their movement, cause more muscle stiffness, leading to more pain. So again, involvement of a mental health specialist again would also be important. So to try and break the vicious cycle, immediately after the surgery, our intervention to try and help in pain management and ambulating these patients is very important. Thank you.
Yes, now, Doc, you talked about multimodal analgesia, and there's a question here about the combination. We have some analgesics that have low doses of paracetamol or an NSAID combined with an opioid. In terms of pain management, would you advocate for those combinations of opioids as opposed to giving the patient a high dose of opioids?
Thank you for that question. And yes, we indeed do have a lot of combined analgesics, but what I would recommend is to try and have a stepwise approach after making your assessment, assessing the severity of pain is when you'll decide on your opioids. But already if you have established the appropriate dosage and the drugs for this treatment, then you can move to use of combined drugs to reduce the disease, the pill burden on these patients. Instead of using multiple drugs, you can have a combined drug. But until unless you have not established the right dose for this patient and the right drugs this patient is using, it's important to start with the one treatment and gradually escalating, and with time introducing a new drug, depending on the severity, introducing a new drug, and then only think of the combined treatment. Thank you. But always remember the non-pharmacological options for chronic pain management play a very, very important role as well. Thank you.
Yes, I think you've tackled the question of regional blocks. Actually, there are some comments here that regional blocks should be considered for some of these chronic pain syndromes that can be managed through interventional pain management. In the month of August, that is the topic we'll be discussing for pain management. What are the interventional techniques that exist for pain management? When do you send a patient for this interventional pain management? Beatrice Murage wants to know, when we are doing pain assessment for patients, as a clinician, how do you manage or prevent bias so that you don't disadvantage your patient? And she says some of the bias that comes could be, for example, female patients, teenagers, or elderly patients sometimes are thought to be malingerers, or patients who have a history of any substance dependence are thought to just be trying to get pain medication and not really to be in pain.
Thank you for that question. It's again a very important question because it comes back down to the basics of medicine and the history taking in these patients. It's always good to begin with, rather than asking like close-ended or direct questions. It's always good to ask like open-ended questions, like what brings you here, and what do you think about the problem that you have? How is it impacting your life? How does your day look like? So that way we'll be able to know how this patient is and what is the functional status of these patients. So not asking like direct questions, but having open-ended questions. That way we'll be able to assess. And then of course, followed by that is our physical examination. And at times, sometimes if you are still in doubt, it's always good to invite a colleague, a fellow clinician, and let them interview the patient. And then you can be able to make a right plan for the patient or a proper assessment for the patient. Yeah, so there are different ways that you can tackle that. Yes, but again, I know there's always that. Remember that pain is very, very subjective, and sometimes these patients might not be, it's not the physical pain that is probably bringing them to the hospital. It's probably the psychosocial part of this pain that is bringing them. So this again brings us to the concept of what we call total pain, where pain can be because of the physical problem or the psychological or social, behavioral, spiritual problem. So again, in your assessment, always remember to try and do a more comprehensive assessment involving the spiritual, psychosocial, and behavioral elements of it. Thank you.
Yeah, now, Doc, what's your opinion on IV infusions for pain management as opposed to oral medication?
Thank you for that question. So what I would say about the IV infusion opposed to oral, you want to minimize interventions as much as you can. And we have evidence showing that the route of administration, there's no superior route of administration. They are equally effective. But depending now, if you're not able to do oral, is when you probably move to subcutaneous.
Sorry, Doc, we lost you.
You want to try and keep it as oral as possible in these patients. Yeah, I think that's what I can talk about for the route of administration. Yeah, thank you.
Yeah, so the questions are becoming more interesting as we go along. There's an anonymous attendee who wants to know the progress of use of clinical marijuana for cancer pain in Kenya. Does it actually work? Is it something that should be pursued for pain management? Cannabinoids.
Thank you so much. I'll be very careful answering that. So what I can say about the use of cannabis, I mean, because it's illegal in Kenya, but what I can say about the use of cannabis, it's very controversial, and it is there's no strong evidence, or you could say like solid evidence to recommend use of marijuana for chronic pain, or even for pain rather. But in the Western world, one of their recommendations say that if patients are where it's legal, and if patients are using marijuana, and if it's helping them, as long as it doesn't cause any adverse effects, then they let them continue to use.
Yeah, I think the challenge with medical marijuana has been getting research because, yes,
yeah,
in a lot of areas, yes, marijuana is illegal, so you cannot do research on a substance that is illegal, and it's illegal in many parts of the world. So it is actually very hard to say that we have evidence, or there's lack of evidence on its use in pain management. But yeah, those limitations are making it hard to do research and actually prove whether it is a good analgesic or not. Prescription. So yeah, great presentation. Some questions here will go to the next presentation. For example, someone is asking about epidural steroid injections for epidural pain management. Philip kindly joined the webinar in August. We'll have the anesthesia team talk to us about interventional pain management. Then patients with liver cirrhosis, what is the best analgesic for them? Then also, please doc comment on use of adjuvants.
Thank you. So I'll begin with on the use of adjuvants. There are various adjuvants that are available that can be used. So again, based on your assessment, remember we said we can classify pain as neuropathic, nociceptive, and then there's another one, the nociplastic type of pain, the new one that is there. So again, based on your assessment, the location where the pain is, there are multiple adjuvants, and the underlying problems or the underlying diseases that are bringing pain, there are various adjuvants that can be used. So for neuropathic pain, actually, you can use the antidepressants, the various tricyclic antidepressants, which can be used. There is anti-epileptics that can be used again for that. And if it's pain because of bone metastasis, then there are other adjuvants like biphosphonates can be used, steroids can also be used in that. So depending now on which type of pain you have is when you'll decide on various adjuvants that you can use to manage this pain. And about the liver cirrhosis, so yes, it's a good question in liver cirrhosis, but from as much as I know that I don't think NSAIDs are contraindicated, but because of liver cirrhosis, you can have kidney problems. Remember that. So use of NSAIDs can worsen that kidney problem and lead to kidney diseases in these patients. And talking of opioids, you can do a trial of opioids, but starting low dose. Usually, you have to be more careful with use of opioids when you have kidney failure. But with liver, you can still do low opioids and gradually escalate. And use of acetaminophen, that's paracetamol, again, with the liver cirrhosis. So there are some authors that say that you can only do up to maximum of 2 grams. That's like, I think 4 tablets of the 500 milligrams that we have in 24 hours. More than that can cause more damage to the liver. So again, but in acute liver injury, you have to be more careful in the use of acetaminophen because of the risk of toxicity. Thank you. Was there any other question? Or just
there are so many questions coming in. I'll help you, Doc, to respond to some of them. So there are some questions and comments about guidelines and just the prescription trends, that sometimes we find a prescription that has multiple opioids or multiple NSAIDs, where a patient is taking more than 1 or 2 NSAIDs with the same content. And I do agree with these comments that it is high time that we developed guidelines on pain management. There are some existing guidelines that management guidelines that we use a lot in our practice. And it would be good if we are able to develop our own local guidelines within our facilities that can guide us in terms of how to prescribe painkillers, even when to choose painkillers. And these pain trainings are also helping in improving the knowledge. Another concern is about healthcare providers being the ones that abuse opioids the most, because they are aware of the different opioids that exist and they know how to obtain these opioids. And there is need for us to support our colleagues and also to put structures in place so that we can be able to limit the rates of opioid misuse among our colleagues. So next month, actually, the topic for pain management, we are going to be looking at how to manage pain in patients with substance or what interventions can we put in place to support and to reduce the rates of I will add the research team, post it on our website so that in case you missed it, you can listen to it. We talked about summary from the question during pregnancy because they cross the placental barrier, or neonatal abstinence syndrome. So the babies who are born to mothers who are using opioids need to be treated for withdrawal symptom. So generally in the first trimester, they are risky because they've been associated with a lot of congenital anomalies and problems with their pregnancy. That trimester, and we use opioids only where the benefits outweigh the risks, and we have to do it in consultation with the gynecologists or obstetricians, because we first have to establish what is the cause of the pain and how are we going to manage the underlying cause of that pain. And the other thing is, what is the plan in case the patient needs to be on opioids? What support are you going to give the pregnant patient and the neonate after delivery? We've actually written a paper on pain management using opioids in pregnancy, and once it is published, we will share the link for those who are interested in that subject. Now, there's someone with a comment here about our practice. Emily has a comment that sometimes we as healthcare providers, we impulsively prescribe or dispense opioids, which ends up masking more serious health conditions. And there are many cases that we can cite of patients who presented in pain. They were quickly given analgesics and no further investigation was as to the cause of pain, and patients end up either a diagnosis is made late or it's missed altogether. So please let us be cautious when we are prescribing analgesics. We are really advocating for patients who come into hospital with pain, not to live with pain. But as you treat the pain, please remember that you have to find the underlying cause of the pain that has brought the patient to the hospital, because you have to treat the underlying condition for you to give your patient overall relief. Now, I would like to take the last question and comment. And if we've not answered any of your questions, please do not take it personally. There are too many questions, and we've tried to link the questions that have something similar so that we can answer together. So someone has asked about migraines, that we will put it as a topic. We've put it in the next pain management series that will start in the next financial year. We are going to talk about the different types of headaches. Now, Dr. Hussein, someone asks about, they want to know your opinion on the ethical issues around euthanasia. They would like to know what your opinion is on the subject of euthanasia, pain, and the patient wants to get euthanasia. Then also just the issue of withdrawing or withholding therapy for chronic pain.
Yeah, I mean, interesting discussion about it here. And I think some